Good morning. We're delighted to be here with you to present a few highlights of San Antonio Breast Cancer Conference from 2020. I am Sramila Aithal, breast oncologist from Cancer Treatment Centers of America, and I have with me here Rebecca Leese. Rebecca?
Hi, and I'm Rebecca Leese, physician assistant in the breast center at Cancer Treatment Centers of America, and we're excited to be with you this morning. I'm going to start the presentation with a case study. And I'm going to present Sharon. She's a 62-year-old female, part-time account executive, postmenopausal, and presented with a palpable mass in her upper inner right breast. After her workup, she was diagnosed with clinical stage 2, hormone receptor positive, HER2 negative, invasive mammary carcinoma with nodal involvement. She underwent lumpectomy and sentinel node biopsy, confirming a 3.1 centimeter grade 2 to 3 lesion with 2 positive sentinel nodes. She had no extranodal extension. She is reluctant to consider adjuvant chemotherapy due to concerns with side effects. She had Oncotype DX genomic assay testing, which showed a recurrence score of 15. She asks if she can avoid chemotherapy. Dr. Aithal, what are your thoughts about Sharon's question?
Rebecca, that's a good question that she asked, because at San Antonio, this was a data presented long awaited, the ExteNET trial. See, previously it was well established that the clinical utility of 21 gene Oncotype DX recurrence score in identifying patients with hormone receptor positive, HER2 negative, lymph node negative breast cancer patients as to who can safely forego chemotherapy. So that was in TAILOR-RX trial, where women under 50 with a score of 16 to 25 may derive benefit from chemotherapy, while women over 50 had no chemotherapy benefit with a score of under 25. It was unclear if TAILOR-RX results could be extrapolated to lymph node positive breast cancer patients. So now we have this ExteNET trial where women with hormone receptor positive, HER2 negative, early stage breast cancer with 1 to 3 positive lymph nodes without any distant metastases were randomized to, first off, went on to have Oncotype recurrence score assay. Based on their score, they were randomized to one of the two arms. If they had a score above 25, they were off of the study and they received chemotherapy based on the high risk of recurrence. However, if they had a score between 0 to 25, they were randomized to receiving either chemotherapy followed by endocrine therapy or endocrine therapy alone. The primary objective of this trial was looking at the effect of chemotherapy on invasive disease-free survival in patients with 1 to 3 positive lymph nodes and a recurrence score of less than 25, and assess whether the effect depends on recurrence score. So here are a few of the demographics, which was fairly balanced in both the arms. Majority of them, as you see, are Caucasians. Postmenopausal women comprised 2/3 of patients. Recurrence score was between 14 to 25 for about 57% of patients. 60% of them had a full axillary node dissection, while about 37% of them had sentinel node biopsy. And about 65% of patients had 1 lymph node positive. It's important to note that there was only about 9% of patients that had 3 positive lymph nodes, and a quarter of those patients had 2 lymph nodes. Again, 2/3 of these patients were intermediate or grade 2 tumors, and 40% of them had T2, T3 lesions. So here are the results of ExteNET study. In this population, women who had a recurrence score of 0 to 25, it did not predict chemotherapy benefit for invasive disease-free survival. So this is in the intent to treat population. The 5-year disease-free survival was 92.4% in the chemotherapy endocrine therapy arm as compared to 91%, with an absolute difference of 1.4% after a follow-up of 5 years plus. However, in a pre-specified analysis, there was significant interaction between chemotherapy and menopausal status. So as you could see in this forest plot curve, in post-menopausal women, women who got endocrine therapy alone, you see them all to the right of one favoring endocrine therapy, although they also had favorable results with chemotherapy and endocrine therapy. Whereas in premenopausal women, you see that there's hardly any patients that derived benefit who, if they received endocrine alone, and majority of these women, regardless of their young age, regardless of tumor size or lymph node status or recurrence score between 0 to 13 or 14 to 25, did derive benefit using chemotherapy followed by endocrine therapy. There were 70% of patients less than 50 years of age. So could ovarian suppression explain chemotherapy benefit in younger women with low Oncotype DX score? Perhaps. So when you look at stratification based on menopausal status, here you see that postmenopausal women, regardless, had no benefit with either chemotherapy plus endocrine therapy versus endocrine therapy alone. Whereas premenopausal, you clearly see the difference here with a change in the delta by more than 5%, 5.2%. So clearly, this results showed that younger women derived benefit with the intermediate risk score on the RxPonder trial with using chemotherapy and endocrine therapy. So based on the recurrence score and menopausal status, if you look at it, with a score of 0 to 13, postmenopausal women had absolutely no difference in the benefit with chemotherapy, endocrine therapy arm versus endocrine alone. And the same to say with the score between 14 to 25. And if you look at the recurrence score in younger women, both the groups, recurrence score groups, derived benefit with an absolute difference varying between 3.9% with a much lower score and 6.2% with intermediate score. So it's very clear, and this is based on the number of nodes and menopausal status, regardless of whether they had one node versus 2 to 3 lymph nodes. Postmenopausal women had no benefit from chemotherapy, adding chemotherapy, whereas younger women, premenopausal, based on their nodal status, did derive benefit with adding chemotherapy. So how should we incorporate this into practice? It's very clear that postmenopausal women with a recurrence score that is low risk or intermediate risk don't seem to get any benefit from chemotherapy. So if they had a score between 0 to 10 or between 11 to 25, they can just receive endocrine therapy alone in postmenopausal women if they had lymph node positive or without lymph node involvement. Well, it also is true that if they had a higher score, more than 25, they will derive benefit with chemotherapy followed by endocrine therapy. Whereas in the premenopausal women, regardless of their nodal status, if they had a score between 0 to 25, they will derive benefit with the addition of chemotherapy followed by endocrine therapy, and the same to say if they had a high risk score. Regardless of the clinical risk status, they seem to get benefit from this. So here we are, our patient asking with 2 lymph node involvement, can she safely undergo chemotherapy? Since she is postmenopausal and having an intermediate risk score, it is safe to say that she can forego chemotherapy. So she asks subsequently, what can I do further to reduce my chances of preventing recurrence of breast cancer in distant sites? Do you have an answer for her, Rebecca?
Yeah, we have some good news. So the Monarch-E trial actually looked at CDK4/6 inhibitor, abemaciclib, using it in high risk, node positive, hormone receptor positive, HER2 negative, early stage breast cancer. This is an adjuvant treatment. And it looked at these women or men with high risk node positive, as I said, hormone receptor positive, HER2 negative. They could be pre or postmenopausal and no distant metastases. at or around 16 months from surgery to randomization. And we looked at these two cohorts, either having equal to or greater than 4 positive axillary lymph nodes, or 1 to 3 positive axillary lymph nodes, plus histologic grade of 3 and or tumor size of equal to or greater than 5 centimeters. And the second cohort was 1 to 3 positive axillary lymph nodes with a high Ki-67 of greater than 20% or equal to 20%, not grade 3, and tumor size less than 5 centimeter. So that's how they kind of quantified the high risk status, was in either of those two cohorts. So here is the breakdown of the two arms. People were either stratified to receive the abemaciclib with 150 milligrams twice daily, and that was up to 2 years, with endocrine therapy for the which was standard of care by the physician's choice for 5 to 10 years as clinically indicated, or just endocrine therapy at the standard of care of the physician's choice for 5 to 10 years as clinically indicated. And here is our graph showing that the CDK4/6 inhibitor arm with endocrine therapy, specifically using the abemaciclib, had a 92% rate of reduction in the invasive disease-free survival versus 88.7% of endocrine therapy alone. And they studied this across various subgroups, as you can see, pretty much across all the subgroups. There was superior results in the study arm using the CDK4/6 inhibitor. Also looking at distant recurrence-free survival, the study arm was also superior and the rates here were 93.6% versus 90.3% when using endocrine therapy alone.
So it clearly goes to show that Monarch E was a positive study where adding abemaciclib CDK4/6 inhibitor in the adjuvant setting reduced invasive disease-free survival in high-risk cases where the risk of recurrence, where we know was high based on their disease clinical features such as nodal involvement, high Ki-67, and so on. But likewise, as we all are familiar, there were two other CDK4/6 inhibitors, palbociclib and ribociclib. Ribociclib is being currently studied in NATALY trial, which, by the way, was closed for accrual on March 8th. And palbociclib was looked at in Penelope as well as in PALACE trial. And the palbociclib was a negative study. So we might ask why that there was differences, although the CDK4/6 inhibitors are identical in their efficacy in metastatic setting. I think there are so many reasons why there might be differences. Majority of patients in PALACE that using palbociclib were N2 or N3 patients, whereas Monarch 1 had many other additional high-risk features like Ki-67 enrolled in the study. The discontinuation rate in PALACE was much higher as compared to Monarch. And one may ask, is there a difference in CDK activity, CDK4 versus 6, where we know that abemaciclib is given continuous dosing as compared to palbociclib 3 weeks on, 1 week off? And is the biology of early stage versus metastatic breast cancer different? We really don't know that. But nevertheless, we do have one positive trial with CDK4/6 inhibitor.
Great, thank you. All right, so let's move on. Dr. Aithal, if this case was in a HER2 positive early stage breast cancer patient, is there any study data that would benefit this group?
Yes, absolutely. Glad you asked the question, because despite appropriate therapy in HER2 positive early stage breast cancer patients, they do have recurrence. So ExteNET trial proved this question and is FDA approved as a single agent for extended adjuvant treatment for early stage HER2 positive breast cancers to follow trastuzumab based therapy. Here's the trial schema for ExteNET trial. In this study, HER2 positive breast cancers who have completed adjuvant trastuzumab along with chemotherapy may or may not have had lymph node involvement. may have had residual disease after neoadjuvant therapy and could have been on endocrine therapy if they were hormone receptor positive, were randomized in a one-to-one fashion to receiving neratinib at 240 milligrams orally daily for 1 year versus placebo for 1 year. They looked at primary endpoint, which was invasive disease-free survival, and few secondary endpoints like disease-free survival in DCIS or time to distant recurrence, brain metastases, overall survivals, and so on. They were stratified based on nodal status and hormone receptor status, as well as concurrent versus sequential trastuzumab. So here's a Kaplan-Meier curves for ExteNET study with invasive disease-free survival and overall survival in all comers intent to treat population. As you could see at 5 years, invasive disease-free survival had an absolute difference of 2.5% with 90.2% favoring neratinib arm and 87.7% favoring placebo arm. There was not much of a difference in the overall survival in the intent to treat population. However, if you look into subgroup analyses, hormone receptor positive patients that were HER2 positive, and if they received neratinib within 1 year from completion of trastuzumab, they benefited with extended adjuvant therapy with neratinib. In this subgroup of patients, invasive disease-free survival, as you could see, had an absolute difference of 5.1% favoring neratinib arm. So also with overall survival with an absolute difference of 2.1%. So another group that where the benefit was noted is in those patients who did not have a pathological complete response to neoadjuvant therapy in hormone receptor positive, HER2 positive breast cancer patients. And in this group, invasive disease-free survival was 7.4% at 5 years, the absolute difference. And the overall survival had an absolute difference of 9.1%, again favoring neratinib arm. In Europe, it is only approved for hormone receptor population, and in US, it's approved for all subgroups. But what we don't know from this study is in patients who have received pertuzumab or based on Catherine data who have received TDM1 in the adjuvant setting, are they still going to get benefit we are not aware of? Another thing is about compliance with neratinib. As we all are familiar, diarrhea is one of the most associated side effects with use of neratinib. But it can be controlled if mandated prophylaxis with antidiarrheals were used. And this is what control study proved, where more than one antidiarrheals were given as a prophylactic measure. And they also looked into dose escalation with 2 doses, and that clearly showed that this group of patients benefited from continuation of therapy with less dose reduction and discontinuation rates. So that is an option now for hormone receptor positive, HER2 positive early stage breast cancer patients, particularly those that did not achieve PAT-CR.
Okay, so we'll move on now to our metastatic breast cancer setting. So can you tell us, Dr. Aithal, about some advances in the treatment of hormone receptor positive, HER2 negative metastatic breast cancer and any novel chemotherapy options for this setting?
Yes, this was an exciting data presentation at San Antonio Breast Cancer 2020. In this subset of patients, hormone receptor positive, HER2 negative, a novel therapy, novel chemotherapy, that's the CONTESSA trial. So as we know that taxanes, particularly paclitaxel, comes in an IV form. And one of the biggest concerns is peripheral neuropathy. And for many of our patients, alopecia is still a big concern. So in this multi-center open label randomized phase 3 trial, CONTESSA trial, Tacetexel is a novel oral taxane, which has shown anti-tumor activity in hormone receptor positive, HER2 negative breast cancer patients. So first off, the benefit of using oral taxane is it has low pill burden. This is given 1 pill every 3 weeks. It also has bioavailability and solubility with long half-life of 8 days. And it's shown to have a potent activity against P-glycoprotein overexpressed tumors. So in this study, hormone receptor positive, HER2 negative metastatic breast cancer with good performance status who may have received 0 to 1 prior chemotherapy regimens in the metastatic setting and could have received any number of endocrine therapy, targeted therapy combinations, were randomized to receiving tacitexel, which is oral taxane, at 27 milligrams per meter squared once every 3 weeks, along with capecitabine at 825 milligrams per meter squared, twice daily dosing for 2 weeks on, 1 week off. And the comparator arm was capecitabine alone at a much higher dose, which we know that our North American patients have difficulty in tolerating this dose. But they continued this therapy until disease progression or unacceptable toxicity. And they looked at primary endpoint, which was progression-free survival by independence review committee, and secondary endpoints such as overall survival. So here are the results of CONTESSA trial. The progression-free survival by independence review committee showed that it favored the combination arm with tacitexel plus capecitabine with a median PFS of 9.8 months as compared to 6.9 months with capecitabine arm alone. The overall response rate also favored oral taxane with capecitabine, showing 57% as compared to 41% and a significant p-value. 24-week disease control rate, once again by independence review committee, also favored tacitexel capecitabine arm as compared to capecitabine alone. So the study showed that there was low rates of alopecia, neuropathy was less, although over time that may be a concern. And overall survival data is still immature. We may not have it until 2022. And another thing is with the intravenous taxane, there is concern with bone marrow suppression. So also with this, and there may be some additional GI toxicity, which is still manageable.
Okay, great. That is some exciting info for some of our metastatic breast cancer patients. So we'll move on to any advances in the treatment of our metastatic triple negative breast cancer patients. What kind of information do we have about those patients?
Yes, in the metastatic triple negative breast cancer patients, we already have been aware of Impassion 130 trial using atezolizumab, immune checkpoint inhibitor, along with nab-paclitaxel, which had shown improved progression-free survival as well as overall survival. And then we also have data from Impassion 131, which was used, where the chemotherapy arm was paclitaxel, which showed that there was no difference in progression-free survival and overall survival in Impassion 131. But now we do have Keynote 355 study, which is a randomized double-blind multi-center phase 3 trial. In this trial, patients with previously untreated metastatic triple negative breast cancer patients who had completed adjuvant or neoadjuvant therapy with a curative intent for at least more than 6 months and developed metastatic disease were randomized to receiving pembrolizumab along with chemotherapy versus placebo with chemotherapy. Now, these patients had to have PD-L1 status checked using a companion diagnostic 22C3 assay for pembrolizumab, which is different from SP142 assay looking for a PD-L1 for atezolizumab. In this trial, the chemotherapy choices that were allowed included paclitaxel or nab-paclitaxel or a combination of carboplatin and gemcitabine. And they continued until disease progression or up to 35 cycles of pembrolizumab. The primary endpoint looked at progression-free survival as well as overall survival, particularly in PD-L1 population with a CPS score that's more than 10 or CPS more than 1, and in all comers. A few secondary endpoints were objective response rates, duration of response, and disease control rate, as well as safety and efficacy. So what the breakdown in this study is that, first off, the median age was around 53 years. Patients who had PD-L1 CPS score more than 10 were around 38%, whereas those that had a PD-L1 CPS score was more than 1 was around 75% or so. So 54% of patients received carboplatin and gemcitabine, while 30% of patients received nab-paclitaxel and 15% of them paclitaxel. So as you could see in 3 groups, maybe a little bit confusing slide here, but there are 3 groups. Progression-free survival was much better in the chemotherapy and pembrolizumab arm in all 3 groups. However, the group that had a CPS score more than 10 outdid the others, regardless of the type of chemotherapy that they received, as you could see the forest plot to the left of 1. No doubt, they also did better with a CPS score of more than 1 and in intent to treat population, but not so statistically significant. The overall response rate was also better with patients that had a CPS score of more than 10 and those that received pembrolizumab with chemotherapy, regardless of the type of chemotherapy, as compared to PD-L1 CPS score more than 1 or in all comers. The duration of response based on the subgroup once again favored pembrolizumab with chemotherapy and outdid in the group that had a CPS score more than 10 at 19.3 months as compared to 7.3 months with chemotherapy alone. Although the other 2 groups also had favorable duration of response to pembrolizumab plus chemotherapy group as compared to chemotherapy alone, but not so statistically significant. So in conclusion, first-line treatment therapy for metastatic triple-negative breast cancer using checkpoint inhibitor with pembrolizumab along with chemotherapy improved progression-free survival in a statistically significant and clinically meaningful way in patients who had PD-L1 CPS score of more than 10 and with the median progression-free survival of 9.7 months as compared to 5.6 months. Well, now one may ask which immune checkpoint inhibitor should we use? I guess it is all based on the type of assay that is utilized to check for PD-L1 status. We do have 2 randomized phase 3 trials that has confirmed benefit of progression-free survival in this subset of patients, one with atezolizumab and second with pembrolizumab, and both have been FDA approved. The overall survival for atezolizumab was also had come out, which had shown an improvement of at least 7.5 months, but we're waiting for overall survival data with pembrolizumab group. So it's important to use a appropriate companion diagnostic test for different immune checkpoint inhibitor, SP142 versus 22C3 assays to determine a CPS score more than 10. No doubt in the future, we may need a better biomarker of benefit than PD-L1. But nevertheless, the options for treating triple-negative breast cancer patients are expanding. Thank you.